Welcome back, everyone. I hope you found that exciting. We loved visiting the individual rooms and hearing all the great ideas. Now we want to hear and let everybody hear the ideas from the group moderators themselves. I'm going to start with Dr. Gattapali. Is he on there? Nope, not yet. He'll come. Brian Stork. Adverse childhood events. Is he on there? Looks like it. Okay, never mind. Chad Jobin and Mary Burns, I'm sorry, did community engagement. Can you guys tell us what you guys discussed? We're having a little technical difficulty, so just a moment. Mary and Chad, can you hear me? Okay.
Now I can.
Perfect. Now I can hear you. So it's a whole new world, this thing. If either one of you want to start and talk about what you guys discussed in your room, I can give it to you.
Sure. Except there's a bad echo. No, there's not. Okay, great. Okay, so Chad and I were in the community engagement room. And so we had a really, I think, rich discussion. And we started with talking about what community we were actually addressing, whether we were addressing our internal community of hospital or whether we were talking about reaching outside of our hospital walls, and that both needed to be addressed at the same time. Primarily first, because there is a lack of knowledge about really complicated problems, or even not only a lack of knowledge, but a refusal or inability to even see things like injustice outside of our hospital walls, or what inequality looks like. And so we wanted to think about ways in which we could both get the attention of the people that we work with our colleagues, and then also the ability to address these problems in meaningful ways, in trustful ways, and mindful ways with our with people that we work with and that we want to reach outside of our community. Chad, do you want to take this next part?
Sure. Well, and I think like one of the primary drivers of that is that we discussed was sort of like building like prolonged trusting relationships with folks within like our constituent communities. Like, folks in the community know what they need. So we need to meet people where they're at and engage community members in meaningful ways and in ongoing ways. So one of the principal thrusts of our discussion was really thinking about like how that might look and how it might be sustained.
We actually came up with a list of some ideas in which these meaningful engagements and interactions look like, that moved beyond simply like DEI training, but started with community advisory boards that already exist in many of the departments within the hospital, but extending a broader voice to these community advisory boards who do a lot of the groundwork and the footwork for the university already and have a lot of community knowledge in terms of how information should be disseminated, what problems exist. But we moved beyond that to think of ways we don't treat communities that we live in and that we serve as experts. And some of those ways is to think about ways we can engage and have these trustful, meaningful relationships where community leaders are the experts, including things like having community grand rounds in each and every department, if not at the hospital level. where my notes sort of stop. Oh, and then DEI initiatives, which also include CME credit. Sorry, my notes are very scribbled and all over the place and not entirely cohesive. Perhaps Chad took better notes.
Oh heavens, no! But we, I would just reiterate what Mary said. I mean, it's about like the sort of deployment, utilization of patients' voice, patients as experts in their own bodies and lives, and being able to like bring that to the table and like share like that experience with the folks within like our hospital community as well.
I love that. Thank you very much, both of you, for your leadership in this space, and we look forward to utilizing you more throughout the year. Next, I'm going to go to Dean Elizabeth Moji and Stephanie Moore, and they had a group on bridging educational gaps.
Hey, everybody. I wanted to thank the group that we worked with, Stephanie and Kristen and Colleen, great contributors. We had a rousing discussion about a gap that we identified as the gap in lack of diversity in the medical profession. So that contributes to some of the things that the prior group was talking about and the need for really working on that diversity gap. And so we then identified some opportunity gaps that lead to this diversity gap, and namely educational opportunity. But we then went deeper and decided that that is fed by economic opportunity or the lack thereof, and that all of those are kind of imbued with the problems of systemic racism. So in particular, we talked about the lack of funding for schools, the lack of economic access for individuals and for community members, and the way that those lacks, the gaps are unequally distributed in our society. So then we identified for solutions that are gaps, if that makes sense. We found a lot of gaps, and every solution then had another set of gaps. So we talked about what we would do, what are some interventions that we could do to try to work on equitable school funding. We talked about the wealth gap, actually trying to push in on and against the wealth gap. We talked about gaps in pathways and services, medical services for children and youth and families. And in that space, we particularly talked about really trying to create pathway navigators who could help children and youth see medical professionals and have different kinds of experiences with those professionals, perhaps less scary experiences, build trusting relationships and begin to see themselves in those roles. And then finally, we talked about K-12 teacher knowledge gaps and the need to help our K-12 teachers work against systemic racism, to be anti-racist in their practice, and to really see the potential of all children to be able to learn and grow. And we talked about really building programs that enable teachers to engage children in the kinds of thinking and projects and questioning and communications and collaboration that will actually build the skills they need, but also build that sense of agency that allows them to move through and across those pathways to try to close the diversity gap in the medical profession. Stephanie, do you want to add anything?
I'll just add a shout out to the Doctors of Tomorrow program and the HOPE Collaborative and some of those ideas. We kept coming back to a lot of the things that you all are already doing and thinking about, like exposing students to possibilities for careers in healthcare and providing tuition assistance, providing training, providing support throughout their post-secondary career. So we're happy that you all are doing what you're doing.
Thank you, Dr. Moore. We're going to go to that program. So we'll have the Doctors of Tomorrow program and developing pipeline programs, which combine. So John Finks, Serena Bidwell, and Jessica Santos Parker will present next.
Okay, thank you. And thanks for that shout out, Stephanie. It's so good to see you virtually. So we kind of started by identifying some of the gaps in pipeline programs. And in thinking about the pipeline, Doctors of Tomorrow really does a good job with high school, but we think that maybe we're not starting early enough. And so we had a discussion about expanding pipelines down to the middle school or elementary school level. And then also thinking about the other end of high school, we discussed ways to kind of fill those leaks for students after high school when they go to college, whether they come to University of Michigan or go somewhere else, and how we can support them and make sure that they have all the resources they need to continue being successful as they kind of progress through their education. And then the other main gap that we really identified was this lack of centralization, especially at University of Michigan, for all the different outreach and pipelining programs that are being worked on and developed right now. Within departments, every department has their own initiatives. Within the med school, there are different student organizations that have their own initiatives. And then even beyond Michigan Medicine, there's work being done in the School of Ed and in other schools. And we're not doing a good job of always talking to each other and letting each other know what resources there are, what's being done, who to contact if you're interested in helping. And so that was kind of one of our main focus areas. And then I'll pass it to Jessica to kind of talk about the next steps.
Yeah, I think that was great. And I think, not just identifying the gaps, but the actionable change or things that we could be doing. And I think, as Serena pointed out, we had a lot of great minds coming to the table that have, all ranges of experience of what they've been doing, and a lot of people already doing great work in this area. And I think the important thing is, recognizing where our group was, developing pipeline programs, but recognizing that there's a lot of barriers in place for underrepresented students, starting all the way from a young age, going through the pipeline, and then even towards the end, incentive for institutions or faculty or stuff to be committed to this type of work. In this group, we talked a lot, not just about systemic racism, but how it can impact, students at every level along the way, and trying to provide support, not just socioeconomic support, but also creating an environment that is supportive and uplifts them, so that when students come, when they're not, going through, it's not them that are failing, it's really we're failing the students. And so things like Serena had pointed out, the big gap is that there's a lot of great people doing work, but we're not communicating because we're doing a disservice to the students who are coming in and, if they're needing support, there's a ton of different avenues instead of a consolidation where we can work together and then we're able to provide kind of more bang for our buck and effort that we're doing. So that's something that we talked about with the HOPE Collaborative and the goals of kind of being able to think about in a pipeline project all the way from elementary school up and supporting through to medical school. But it's not just one department that is, trying to put forward the effort. It's really all the departments, the institution that's coming together to provide the best support. So kind of also having then a centralized, committee that is working together and those resources are available to everyone. And then really important to recognize, the people, and they're often people of color that are doing the work in this space for years and years, and really utilizing them and supporting them instead of coming in and thinking we're coming up with new ideas. But our group was really great to hear all the passion. I don't know, Dr. Finks, if you have anything else, you were a great support in the group for us.
Yeah, thanks. So you guys did a great job leading that session. I think, I think you covered most of the key points. I think one, in terms of steps we can make, we talk about small achievable steps. And one, I think, relatively straightforward one would be to just start a working group that meets, a month or every couple of months of people who are doing active pipeline work currently at U of M, of which there's several. There's DOT, or I know that ophthalmology has a program. There's other programs sort of scattered throughout the medical school, and trying to bring them together so that we work as one coordinated group. And I think we could probably do that pretty easily. Just having a monthly meeting would be one place to start. And one of the points that was brought up by Dr. Lucas was the fact that the bigger we are, the more likely we are to attract institutional support, financial support specifically. So that's even more motivation to do that.
Those are Great ideas. Thank you so much. We do hope to do that. Dr. Stork, adverse childhood events.
Yes, thank you. I had the privilege of having a small but very mighty group to work with on adverse childhood experiences, which in many ways is childhood trauma. As may have been discussed, there was a very large study performed in the mid-90s of 17,000 persons in California that showed that exposure to childhood trauma can lead to lifelong lasting behavioral health and mental health issues. And so obviously those exposures, which are felt to be cumulative or dose dependent, can affect the pipeline of future physicians that we ultimately have taking care of patients in our communities. And we also know that minority persons are more likely to have exposure to childhood trauma. So in many ways, these things overlap like a Venn diagram. I'd like to thank my group for having patience with the technical difficulties today. What we did discuss is that this knowledge about childhood trauma and ACEs really has not permeated its way through all of medicine and academia. Within my own community, it really began with community services and has sort of worked its way upwards towards medicine. So we think that there's a lack of knowledge. We think that there would be a benefit from discussing this science with our colleagues, with medical students, and with residents. And we also think that people who have a history of childhood trauma are stigmatized, that nobody wants to come out and say, hey, my parents were divorced, my dad was an alcoholic, and my mom was bipolar. Nobody wants to admit that at a medical school interview, or really even on day-to-day interactions with their colleagues. We talked about the fact that persons with ACEs, in order to survive, become very good actors, and they want to fit in, and they don't want to ruffle any feathers. So sometimes it really takes some digging to find out who's had this history of childhood trauma. There is a 10-question ACEs screening tool that has been used. There's some other screening tools as well. But one of our participants, I think, rather astutely said, what kind of challenges have you had, as a question to some of her patients and students working with her, which opens the door, I think, for people to talk about the things in their life that have been challenging for them. And then also, what do you think your strengths are, which I think is a way of talking about resilience and what a person feels their resilient mechanisms are. We would agree with the Doctors of Tomorrow observations that we think awareness of childhood trauma and the effects of adverse childhood experiences needs to move farther and farther towards the elementary school age. But at the same time, we also feel that persons who are coming in for medical school are under a lot of stress. Residency is a lot of stress. And perhaps by at the start of these academic ventures, having a mentor step up and say, hey, you know, this is a stressful time. A lot of us here have had these experiences. We have an open door. We're happy to talk to you about how those childhood experiences may impact the stress that you feel on a day-to-day basis. So I think in summary, the thought on this was that we need to increase knowledge, that we need to be more involved in our communities, not only our medical community, but also our school communities and our community in general. I will just say that having trained in rural hospitals in Iowa, these old-time doctors lived in their communities. They took your appendix out, they'd do a hysterectomy, they'd go to church on Sunday, and they were head of the JCs. So they knew what was going on in the community. They didn't need ACEs theory. And I feel like as we've become more and more specialized, and medicine has really consolidated, that we've maybe lost that intimate connection with our communities a little bit. And I think we really need to regain that. And then finally, one of our participants said, if you don't see it, you can't be it. And so I think that as physicians who maybe have had childhood experiences, we need to be the mentors for others to say, look, you can get through this. We can help you through this. This is not a barrier, but it may be just one more challenge. And I thank you for the opportunity to summarize, and I hope I did my group justice.
That was great. Thank you so much. And last but definitely not least is my friend and partner, Dr. Samir Gadapali, who's going to talk about health equity research and health equity policies.
Yeah, hi. Thank you for giving me a chance to present. Presenting on behalf of our whole group, which included Bill Palazzolo, Dr. Chen, Dr. Myers, and Dr. Scott, who I think he said he was an agent of SHIELD, like a health policy avenger. And so I think I understood that correctly. So we primarily focused on, so we started out with looking at issues with current policies with an equity lens. We identified that, a lot of health policies had intended and unintended consequences, and kind of identifying who a policy affects might really be helpful, because the purpose of a policy might be around housing or tax or registration, but then has downstream impacts and consequences. And all along that pathway of that policy, disparities among populations get magnified. So for example, we said, okay, we should do virtual clinics. We will be able to talk to families and, be in their houses. But the problem is, what if they don't have a house? What if their Wi-Fi connection sucks? What if they have to be at a job? All of these little things in between that pathway impact the final effect. And so you may actually find that you've increased your disparities with your policy rather than decreasing the disparity. And then we also talked about how we have to think about being anti-racist policies and then having anti-racist policies, two different things. So we have policies that are racist, and we have to be against those. And then we have to create new policies that are anti-racist. And those are both important concepts. And then passing a policy doesn't necessarily guarantee its implementation. An example of this was, for example, a Medicaid expansion, which, would have addressed a lot of access to insurance. However, not all the states adopted this, and it happens to be more likely in states that have a larger population of African Americans, Blacks. And so it actually makes some of the disparities even worse. And so identifying not just having the policy, but how the policy then gets implemented becomes really important. We looked at gaps that we wanted to address and came up with about 5 or 6 kind of overarching gaps. Access to care, such as insurance and how to get to a hospital. Access to innovation, which would be things like technology, getting virtual visits, having laparoscopy or ultrasound, things that we almost take for granted at certain institutions. And then education, communication, and language, like how policies are conveyed to different groups can be very challenging. Looking at outcomes from a patient-centric point of view, including quality of life and quality of care, to help define health equity better. And then we talked about various interventions and how along the pathway things, the system gets gained. So for example, an example was decreasing the reimbursement for a type of breast reconstruction led to decreased utilization of certain types of procedures, which actually led to an increase in disparities among different populations. And so, who actually benefits from policy that get created is really important to look at. And then hiring practices, not just, and just doing a bunch of interviews of a more diverse population does not really reflect the population that's being served. So really looking at the different policies and interventions and how they can be gained, almost creating a dashboard where you have each of these pathways that are being measured rather than just the eventual outcome of what your policy was supposed to address. We thought that, the understanding of the root cause of the gaps was actually part of the health equity research takeaway. Studying and understanding these policies that lead to racist outcomes and identifying what the drivers are is really our first step in terms of defining health equities. And then creating new policies, both like I talked about, anti-racist policies and anti-racist policies. Looking at things like, telehealth, access to breast reconstruction, things like that. And then finally, prioritizing at-risk groups by actually incorporating them within our studies. And by that, I don't mean putting them in the model. So just because you added race to the model, it doesn't necessarily explain why this disparity exists within the model. You should really ask, why are we including that race? And the best way to do that is actually incorporating them within your studies, meaning having populations that are impacted help design the study and help implement the study. So including populations that you're trying to help and trying to build equity within, having them as part of your core group in doing the research. Thanks for allowing me to present.
Thank you. Thanks to all of you for your help here. We're going to continue to utilize you through the years and all of your expertise.